Welcome, everybody, to the Amplify Long-Term Care Podcast. This is your host, Frances Nahas. I am super excited for our guest today, Thomas Hanzel. Tom, why don't you go ahead and introduce yourself?
Yeah, well, thank you. First of all, I want to thank Frances, you and Amplify for getting the chance to come on here and talk with you. And of course, RedSail for organizing all this stuff. So very excited to talk with you.
We're lucky to have you.
Yeah. Well, I appreciate it. I don't know about that, but I surely have been given the gift of gab. So I enjoy talking and enjoy meeting people and whatnot. So a little bit about myself personally. My wife tells me I'm happily married. So no, certainly happily married. We've got 3 beautiful daughters, and you might be able to see a picture of the family there.
Yep,
they're
yep.
behind me. So I take them wherever I go. But my 2 oldest girls, they play competitive soccer.
Wow.
Their whole lives. So any parent that has been on a baseball diamond or a soccer field for like every weekend for 15 straight years will understand what our lives are
What your
like.
weekends look like every weekend.
Yes.
Yeah.
Very busy. And that actually accumulated into them getting to play college soccer together on the same team. So
that's fantastic.
that was a lot
That can't
of
happen
fun.
very often.
No, it certainly was an exciting time. And gosh, I don't know. I'd like to be adventurous,
Yeah.
I I skydived and got to drive a NASCAR 165 miles per
Nice.
hour, which is, probably not a good decision, but I survived, So I like to do stuff like that. And I love to. I'm a big Pittsburgh fan.
I was going to say, pause a minute, because I know you're based in Raleigh, and that is decidedly not a Carolinas Panthers
No.
swag behind you.
Yeah, I'm originally from Pittsburgh, so I bleed black and gold, but there's more bleeding right now than there is anything else.
There are a few folks on our team who will sympathize with you, who are also long-term, deep Pittsburgh folks. So,
Yes.
you're in good company.
Yeah, it's in the DNA. I certainly can't get away from it, and certainly don't want to. So, but that's me personally. Professionally, I am a pharmacist and graduated in years ago. So been a while, but I spent my whole career really in long-term care, pharmacy operations and automation, and certainly love that. Love long-term care, and that's where I want to be at, and what do I remain at. Now my mission is really focused on helping fight for pharmacies and helping fight for the industry, and so I wake up every day trying to figure out, what I can do to help pharmacies and help them improve and help them strategically grow and innovate, and help companies like yourself, any organization that's trying to help the practice of long-term care pharmacy and pharmacy in general, then I'm here to support. And big reason why I'm anxious to get on this podcast here with you, because I want to help wherever I can.
Fantastic. Well, tell me how you ended up in pharmacy.
Well, it's actually probably a very uninspiring story, or uninspiring.
I'm glad I asked that. I'm excited.
Yeah. I picked pharmacy for all the wrong reasons. I grew up in a small town, and your options were be a coal miner, which my dad was, be a farmer, or join the Army. And I wasn't man enough to do any of those things. So I was working a front end, like cashier, kind of like it's actually called Hooks. Do you remember the pharmacy chain Hooks?
Nope.
Yeah.
Nope. You got me on that one. But I didn't grow up in the Pittsburgh area. I just lived there for a couple of years.
Well, actually I moved. It was actually in Illinois. So I was born in Pittsburgh, but it's in the Midwest, and they were a decent sized regional chain. And I sat there as the cashier and watched this guy sit back there above ground, right, versus what my dad was doing. And in the air condition, I thought, I want that job.
Right.
And so that's why I got into pharmacy. And then, I got out and started dispensing drugs, and I thought, I hate this. And fortunately, I found long-term care and fell in love with it. And really, I never looked back. It just was long-term care from there on out.
That's fantastic. So tell us a little bit about what you're doing today in long-term care.
Yeah, like I said earlier, it's really any way that I can help pharmacies improve and help them be strategic and help them be innovative. A pharmacy is when it comes to, if you compare to other industries, when it comes to technology and innovation, we're like 50 years behind other industries. They had things like just-in-time inventory at Toyota back in the 1970s, before I was born, and every pharmacy that I walk into is overstocked somehow, some way, or can't, prepare and anticipate, I guess, well. And we all try. But, I think that there's just so much software and innovation technologies out there that really aren't customized for pharmacies yet. And so I'm spending a lot of time working with some new softwares and new technologies and trying to evolve them and adapt them for our industry. But even besides that, kind of future plan, just going in and helping pharmacies improve, helping them diversify their revenue, helping them think about ways that they can generate more revenue without necessarily having to go out and add another nursing home or have to go out and fight for a handful of customers and patients. And there's just a lot of different things and a lot of different strategies that pharmacies seem to be aware of, but not understand how to incorporate. And so I really try to give them kind of strategy on looking at all these different options out there.
So I'd love to pull on both of those threads. I'm going to start with the technology one.
Okay.
So you mentioned, there's a lot of tools that, well, first of all, the technology in pharmacy is just very old in most cases. This is so the truth. We're working to change that. We're working to change that at RedSail, but it's very much the truth in healthcare in general.
Yep.
And also true that you go to other industries and you can't just take a solution for an industry that's not healthcare and plop it into healthcare. And I know when I worked on the hospital side of pharmacy, one of the things we looked at was just supply chain management for drugs. And you couldn't use an off-the-shelf system because they can't handle things like liquids, right? And that you might only use part of a vial, right? That it just wasn't structured to handle that. So what are some of the things that you encounter where there aren't solutions that exist today? And how do you think about how you get solutions into a pharmacy?
Yeah, no, great question. And, when it comes to packaging and dispensing, that's where most of the technology has advanced in pharmacy. And, being able to spend that time at Parada and utilize those machines in my pharmacies and that kind of stuff in the past, being able to work with pharmacies across the nation on different packaging solutions, that certainly has done very well. Even the vision system where you're taking a photo of that pill or of that capsule, being able to mirror that off of your database and verify that that's accurate, those solutions are there. Really, when it comes to upfront, though, and I mean like triage, billing, order input, those type of things, we're still in a very labor-intense market.
Right.
It's manual input, it's manual transactions, manual billing, adjudicate, get rejected, rebill, adjudicate, get rejected. Those type of just continue to throw people at the problem. And I think that's probably the area that's going to be of the most need. Then we just talk about maybe being more pioneering, like clinical billing, RPM, MTM. We can certainly dive into any one of those, but looking at technologies that look at revenue that's outside of the dispensing of the medications, outside of the reimbursement or the passing out of the medications, and more into the clinical side, the billing side of finding resources and revenue that you can generate growth off of.
Yeah, so that's a great transition. Let's talk growth opportunities, right? So obviously for long-term care, filling that medication and sending that off to facilities, kind of the core of the business. What are those opportunities that pharmacies should think about growing that don't involve getting a new facility?
Yeah, I always like to start with maximizing your current clientele, your current patient base. For example, it's amazing how we'll send prescriptions up to like a CCRC campus, right? Community campus has got we're servicing the skilled building, we're servicing the AL building, but those 700 IL patients, we're kind of just like, they don't exist. We're kind of ignoring those. And yet we're delivering to that campus 7 days a week. And they're out getting their medications from Amazon or Walmart or local independent pharmacies. And so, finding different creative ways to market to them, to make it capable for them to get their medications from your pharmacy, and then incentivizing them with other different programs. So, for example, I've got a friend that started a vitamin program. Vitamins, there's a great non-PBM dependent revenue source. 77% of all Americans take vitamins. The older they get, the more vitamins they take. You've got companies out there that I got a chance to work with that use the same machines that we use to package medications into the pouches, and they're shipping vitamins all over the world. There's just no reason why pharmacies can't, that current population, that current customer base of AL and IL specifically, to market their vitamins, to market over the counters and those type of things. So taking care of that current population and make sure you maximize the revenue of the current population that you're really servicing right there. Then, to really grow outside of that, as far as kind of diversifying your offering, I see pharmacies like, we've been doing unit dose blister since 1990, and we're going to do unit dose blister till 2090,
Right.
And they get very, tunnel vision on that. But the most successful pharmacies that I've seen in America, they don't let packaging type limit their opportunities. They'll do anything. You want unit dose blister, you have array of multi-dose blister, you have unit dose pouch, multi-dose pouch, a Tromic box vial. Heck, I don't even care if you deliver by carrier pigeon. Just don't let that limit you and limit
Right.
your growth. And if you don't let packaging type limit your growth, you can get a seat at any table. You can go after any market, whether it be PACE, behavioral health, prison systems, group homes. I mean, there's so many different markets that you can specialize and go after. And so that probably brings me to the next thing, which is looking at your current community and your current offerings and meeting the need where it's at. So, for example, of this is a company like Hims Hers.
Mm-hmm.
These are brilliant people. They picked one disease state and one drug and said, we're the best at it.
Right.
We could do this better than anyone else. And they've made hundreds of millions of dollars. Now, I'm sure they offer more than that now, but there are needs in your market that you can get that niche, that you can advertise, you can market to, you can tell people about. I had a friend who started back in the early 90s an HIV pharmacy.
Mm-hmm.
Now they're a multi-billion international pharmacy.
Wow.
But they said, we're the best at this. We're the
Right.
best at doing this. And they let the world know about it. And so, finding that niche, finding your strengths and your personnel strengths, and really just kind of marketing to focus or specialize in those areas.
What about revenue diversification between sort of pharmacy and clinical services? How should they think about that?
Yeah. Another great question. There's all kinds of new opportunities out there. Maybe not necessarily new is the right word. There's all kinds of opportunities that exist currently that pharmacies have ignored.
Mm-hmm.
So incident to billing is a good example. RPM is now a new pioneering example where, we can bill under the provider, under RPM, under incident to, and we can get non-PBM revenue, we can get
Right.
provider revenue, and really helps us diversify outside of, again, being dependent upon, I have to dispense this drug and get reimbursed for this much of that drug. Now we can talk about growing our pharmacies. I got a friend who lives in England and works with pharmacies in England. And he said, boy, for years, our pharmacies are being paid to do consulting, to do screenings and those type of things. He said, but we're not resting in our laurels. They actually have, we could talk about this later, they have provider status on some lower element stuff like sinusitis and UTIs
Mm-hmm.
and birth controls and those type of things. But they're not even stopping there. They're creating in their community kind of a one-stop shop where they want everyone in the community to come there. So they're building out separate rooms for dermatologists, for acupuncturists, for holistic therapists, and all those type of things under their umbrella. They're renting their space out, and they're matching their over-the-counter products and their items to go with that. So when that patient comes in to get their drugs, go to their acupuncturist, go to their holistic therapist, go to their masseuse, whatever it is, and they're trying to be a one-stop shop, and they're generating revenue in all different types of places.
That's super interesting. So it's similar almost in concept to the CVS and the Walgreens Minute Clinic, but they said, hey, let's just go out into our community and find those folks where there's a there's a natural match
Yeah,
and make sure
absolutely.
we're actually in a symbiotic relationship and referring patients and providing a connected service.
Right. They're investing in being a part of their community. They're drawing their community in. They're really going after, in many ways, that low-hanging fruit, and they're trying to be a one-stop shop. Walmart kind of tried to do this.
Right.
They'll put a bank in and a pharmacy in and eye doctor and everything else. And, it doesn't have to be that robust, as a Walmart, but the concept is I don't have to just dispense drugs and just to deal with that and just be stuck in that environment. I'm a healthcare provider, and I can do that in many different ways.
Super interesting. So anything else on sort of the revenue side that you feel like folks are kind of ripe opportunities that pharmacies may or may not be looking at yet?
Well, the biggest trigger word out there right now is long-term care at home, right?
Right.
I mean, that's
right.
Everybody's talking about it. No one knows how to do it.
Yeah.
At the end of the day, it's lower reimbursement, but and higher delivery cost. But this is where the market's headed. Our senior population is going to grow by 50% over the next 6-7 years. And, come the year 2030, I mean, that's the apex, right? They're not going to all just cease to exist. That's just the apex of the growth. And so, you have to move where the population's growing. You go back to Blockbuster and Netflix. Blockbuster's like, nope, we are going to stick with in-house, in-store, come pick it up and that kind of thing. They didn't evolve. They chose not to evolve. They actually had a chance to purchase Netflix, and they chose not to. And, of course, Blockbuster really doesn't exist anymore, and Netflix is dominating the world.
Right.
But this is the same thing. If pharmacies stay confined, long-term care pharmacies specifically stay confined to the four walls of a nursing home, and they even though it's hard and even though it's not as good reimbursement, it's a quantity game. We have to organize our pharmacy, which isn't a big lift. I mean, those patients need everything a long-term care patient residing in a nursing home needs, but we have to customize and create a separate division, almost, if you will, to properly service these patients. And they're going to be there. This patient's going to be there. They're getting their medications from somewhere. They might as well get it from the best pharmacies in America, which is long-term care pharmacies, because we're the most qualified to really meet these patients where they're at.
Right. It is that bridge, right? It's an in-between being in a facility where you have a nurse who's doing rounds and dropping off meds and being truly a community, pharmacy experience where the patient's going to walk in and pick up the meds. So it's how do you figure out that in between?
Yeah, absolutely. It's not easy, but it's that's where the money's going. That's where the shift is going. And so, it's really not a matter of how to do it as much. I think we're going to get that figured out. The question is who's going to be first, who's going to make the biggest impact, and who's going to kind of lead the pack in that way.
Right. How do you think about automation, right? You've spent years working with automation. How do you think about that and how it fits into the story in terms of how you can grow how you can grow revenue, right? How you use the tools that are available to you to drive growth?
Yeah, another good question. Again, I think when it comes to the different packaging formulations, whether it's pouch or blister or vial, I think you need to offer anything and everything created under the sun. That way, you at least have the opportunity to get that business. But to me, it's about maximizing the tools that you have at your disposal. Pharmacies get very tunnel vision on dispensing the drug, but you've got more data, more analytics, and more opportunity to utilize that than almost anyone. And it's a matter of, I believe, taking that data, taking that analytics, and really transforming your pharmacy to look for formulary opportunities, to look for ways to, again, add resources and maybe medications that are clinically appropriate onto your current customer base, but also to be able to utilize that data as far as market analysis and be able to where I'm going to grow and how I'm going to be able to most cost effectively be able to go after the gaps that exist in our business. We've got a real serious problem in America today called a nursing shortage.
Yep.
And the U.S. Bureau of Labor, I was reading, said there's going to be something like, as the baby boomers age out, there's going to be something like 175,000 nurse job opportunities available every year, but 220,000 nurses coming into the market over the next 5 years. Which,
right.
I got my abacus out and I started using that, and I'm like, that's going to be like 1.5 million nurses short.
Right.
Nursing homes certainly need as much help as they can get. And to be able to make them more efficient should be our highest priority. To make them MedPass more efficient to be our highest priority. Multi-dose blister, multi-dose pouch does just that. In my experience, it reduces the MedPass time by 35%.
Wow.
And that's pretty significant when you have a nursing shortage and it takes 2-hour window to pass those meds. But now they can utilize their nurses and their staff to be able to do other things that are more clinically appropriate. Let's take that a little step further on the discharge to home program. I ask this question all the time. I'm in a group of pharmacists and I say, how many people are doing discharge to home med program? Maybe 10% raise their hand. And to me, it's a low-hanging revenue fruit. The facility needs it because they don't want rehospitalization. And that's the number one reason why there's rehospitalization, because of lack of compliance. Right. The patient certainly needs it as they transition from one setting to another. But for the pharmacy, it's a no-brainer revenue opportunity. You already have that patient.
Right. You have more information than anyone else does about the patient and their meds. Right. Yeah.
I had a buddy that was going to start that program. He's going to call it Follow Me Home. I thought that's a little creepy. I'd probably do something a little different. But it is. It's following that patient home. And then, obviously if you can keep that patient, great. But if you think about that residence in that skilled nursing facility, let's say is a rehab patient for 4 weeks, you set a 2-week supply at long-term care rates. Now you've got 6 weeks of medications instead of 4. Right. So I just doubled my revenue by 50% for that patient.
And it's good for the patient right?
Everybody wins. Yeah. Everybody wins. So it's programs like that seem to people are aware of, but they don't go after. PACE is a good example. PACE is it's kind of a hybrid between the long-term care home and the nursing home setting. That's another non-PBM revenue generating department or area, because you negotiate your rates directly with that PACE program. And that's something that I think there's 32 states that offer PACE, and that continues to grow. But there's something like 880,000 patients that are PACE eligible that just haven't gotten to the PACE program, because that continue to grow. But there's another area that you could specialize in, but another revenue area that you can have. It takes technology to be able to do that, because you're going to have to offer certain packaging types and that kind of stuff. So I certainly think that you can, utilize your packaging or your technology to be able to grow in those areas.
If you're a pharmacy and you've listened to all of this and you're just like, okay, there's so many really good ideas. Where do you start? Right? We think about this in our business all the time, right? We've got so many really good ideas. It's hard to choose. It's hard to table some of them. So how do you whittle that down to where do you focus today?
Well, another good question. And I think you really have to start internally, obviously, and look at your strength and look at your team strength. You might have 2 or 3 pharmacists that are already vaccine certified.
Yep.
Why can't I start a vaccine clinic? Why can't I grow that vaccine clinic across the state? Again, another non-PBM revenue opportunity to be able to get that. Maybe you have pharmacists and or technicians that specialize in a certain area or their background. So I would certainly look internally to see, what do I already have at my disposal? What do I already have? I would look at my current systems. I already have these systems, but maybe I'm just not maximizing their potential of my technology that currently exists. What can I do? Instead of going out and buying more machines or hiring more people, what can I do that's already at my disposal? And then I think next you need to look at your community. What's not really here that I can specialize in, that I can do, that I can promote, whether it's your community of customers or your community, the town that you live in, and those type of things. There's certain parts of the country that are very dominant in one area, or very dominant in another area, but that just means that they're kind of locked in, to that environment. And so, the best pioneers really come in and say, yeah, this is going to be hard, but I'm going to take this proven solution and I'm going to do it here in this part of the country because it worked in other parts of the country. It's going to work here, and I can make this successful here, And so I think pharmacists oftentimes they get they get kind of, I don't know, conditioned to their environment, and again, I'm one of them, so I can kind of talk bad about myself because I used to do that a lot. But it reminds me of that story of the flea, like the insect, the bug, the flea. People don't know this, but they know fleas can jump, but a flea can actually jump 2 to 3 feet. That'd be like you or I jumping over the Golden Gate Bridge.
Yeah, exactly. Like several stories in the air, totally normal.
But if you take that flea and you put them in a mayonnaise jar or a pickle jar and you put a lid on it, that flea is going to hit its head so many times, and then it's going to get conditioned to its environment. And it's not even going to try anymore. It's just going to stay focused on their environment. And I think we've done that as an industry. We just got very pigeonholed in our environment. But, until you take the lid off, you can never know how far you can go and how far you can jump, and we only kind of have ourselves to blame. I mean, we've allowed ourselves to be at the basement of hospitals.
Yep.
We've allowed ourselves to be controlled and manipulated by PBMs. We've allowed ourselves to have to ask permission from doctors and the government to be able to participate in healthcare.
Right.
Yet, at the end of the day, is we've got a pharmacy in almost every town in America.
It's the most accessible healthcare, right? Anyway.
Yeah. So most accessible healthcare. And said, we really got to come together and say, I'm not going to continue being confined and held to what the past is and not be reactive. I can't stand still. I really got to be proactive. I really got to push the limits when it comes to technology, and I've got to look outside that standard getting paid for drugs less and less and less every year.
Right.
And I've got to think outside the 4 walls of a nursing home and outside the PBM, and I got to get innovation in and be able to customize that to where the industry's headed, where the future is going.
Yeah. How much does regulatory play a role in that?
Well, pretty substantially here recently.
Yeah.
Boy, should I tell you, we all celebrated that we got the focus about DIR fees,
right? Until
they passed a law that definitely helped patients, and we're excited about that, at least copay patients, but it didn't do pharmacies any good. In fact, come up here Q1.
It's going to be a tough Q1, right?
Oh my goodness. Pharmacies that deal with DIR fees are going to get double whammied. And I tell you, I don't know how many of them are going to survive. I don't even know if they're really aware of the fact they're going to get paid less.
So for folks who may not be, let's walk through what's happening in Q1 then.
Yeah. So, the government came out and when they realized, and that's usually what it takes. It really takes that there's going to be harm to the public for them to react. And there was harm to the public. So, what PBMs were doing is they were charging $10 and they were charging a copay for that. And then 5 months later, they went back to the pharmacist and said, no, we should have paid you $5. We're taking back $5. Except that patient already paid 20% of that $10. They really should pay 20% of the $5. And so the government said, you can't do that anymore. And so the PBM said, okay, with us, no problem. We're still going to only reimburse $5, but we're going to do that now. In January 1st, we're going to only reimburse $5, except you still got the Q4 DIR fees. They're going to be hitting pharmacies.
Yeah, so they'll get the retroactive hit from Q4 while getting the real-time hit from Q1 all at the same time. So basically a double hit of DIR fees all in one quarter.
Yep.
Yeah.
Absolutely. And now, we're getting a lot of attention about PBMs in Congress.
Yeah.
There's a lot of conversation going in. 3 years ago, you probably couldn't name 2 congressmen and women that even knew what a PBM stood for.
Right.
Now they're all aware, which is good. But they all want to put their bill in, and they all want to kind of pass their laws. And at the end of the day, if it ends up like the DIR did, then it's really not going to do any good. And really, we need Congress to pass one law, which is PBM transparency.
Yeah. How much can you do locally versus waiting on the federal government?
Well, I tell you, pharmacists at one point, I don't know if it's still thought of this, but pharmacy at one point was the most trusted profession.
Yeah.
And I'm sure we're pretty
still
high
in the
up there
top 10,
still.
probably.
Yeah.
We can go get the stat, but yeah, still pretty high.
But I think most people appreciate their local pharmacist, even if they, regardless they work for a large chain or whatever. I think long-term care pharmacies are a good example of just a hidden secret. That's a nursing home thing and that kind of stuff. And vaccine clinics are a good example of how you can get out to the public. You can get a name recognition, a brand name recognition for your long-term care pharmacy. You can go out and start offering things, like vitamin programs, like over-the-counter programs and those type of things. You can go out and start, again, offering different services to your public and make that awareness and be the fact that, we can do this, especially if you're going to go into long-term care at home. You really need to brand your pharmacy. You really need to publicize that. As far as moving the envelope, I think it's really important to get state congressmen and women, state senators into your long-term care pharmacies and show them what you do and how you do it. Explain to them why your reimbursement is so critical, because you're doing all this extra stuff. And really, whether that long-term care patient resides at home or in a nursing home or in an AL home or an IL home, you should be compensated the same, because your services you're providing is significantly more. But they need to understand that. I mean, these men and women are voting for different things, but yet they're voting. They have no idea what a long-term care pharmacy is or how PBMs are taking majority of the market share and that kind of stuff. And so, getting involved. And then, of course, the associations, supporting your associations like ASCP and SCPC and those type of things are critical. And the reason why is because they're fighting for us, and there's volume in numbers. It's just that simple. So I see a lot of times where the pharmacy is part of the ASCP, but every pharmacist and every career technician that works at that long-term care pharmacy should be a member of ASCP, because there's magnitude in that kind of volume, and we can get more attention with the more volume of people that we're representing. So getting involved in those associations, I think, are critical.
That's fantastic. Yeah. What else? What should I have asked you that I haven't yet?
Gosh, I don't know. My favorite color? No. It's black and gold, by the way.
Shocking. No, I can't imagine why.
No, I think, probably one of the things that we haven't talked about is the importance of provider status. Mm-hmm. I think that's another thing pharmacies should fight for. Yeah. And every time I talk about that, they give me the eye roll, like, oh, that's never going to happen, But with that nursing shortage we talked about is happening. The fact that we're going to be flooded in the marketplace with all these seniors, these people that are really going to be truly long-term care patients, but they're just not going to be residing in a nursing facility. The shortage of nurses, the shortage of primary care physicians. It's going to be critical that pharmacists have at least basic level provider status, not just vaccines, but the same thing that they're doing in England, to be able to do, basic sinusitis, UTIs, common colds, birth control, those type of things, because we're so attainable, we're so reachable. And so fighting for that, that's not like a wish list. I think it's going to be essential to United States healthcare.
I agree. Essential to United States healthcare. And I think critical to getting paid for the services that are provided, right? So there's so much within pharmacy today where there's counseling or there's conversations that are provided today, and there's not a method to get that reimbursement or to get paid for the work that's being done. And so it's a critical,
midwives have more prescribing rights than pharmacists do, or something.
Right.
But that's where the population is going to be at. That's where the United States is going to be at. They're going to be 2 hours away from that hospital or whatever it is. And so what I'm afraid is going to happen is the population's going to get there. There's going to be needs. There's going to be long waits. There's going to be nursing shortage or primary care shortage. And then something tragic is going to happen. Yeah. And then finally, when there's turmoil, finally Congress is going to like, oh, hey, how can we have prevented this? How can we decrease the lines at the doctor's office? And we see this already happening in England, and that's why they gave those pharmacists, those type of rights.
Well, all the leading indicators are here also, right? If you look at physician burnout, if you look at shortage of nurses, if you look at the aging population, right? We know who takes the medications. Right. The older you get, the more you take.
Yep. And it's going 50% over the next 5-6
Right.
years. And so, we're going to be overwhelmed with it, and our system's going to be overwhelmed with it. And then I think the next big thing is defining long-term care patient,
right,
independent of their residency. And I think that's what you're talking about earlier of being reimbursed. We should be reimbursed based on the patient's needs, not based on where the patient lives or the patient resides. And I think if they base their payments based off that patient's needs, and we as a long-term care pharmacy or even long-term care home pharmacy, we're servicing those patients and we're meeting those needs and we're providing better outcomes. We're keeping them out of the hospital. We're keeping them out of the nursing home. That's where we should get paid at. So they get into this retail and where they reside, but it really should be based on the patient and what the patient needs, not necessarily where they reside. So I think that's also something big we need to fight and push for.
Yeah, it is. It's really, if you think of, it's this separation or dichotomy between what a hospital pharmacist does and the value that's perceived in that, right, of sort of all of the med rec and all of understanding sort of the complexity of a patient that might be on a lot of meds or dosing those particular meds versus retail pharmacy, where it's often just seen as like the value's the cost of the drug, right, or the price of the drug. Right. It's not the service that's being provided around it. Right. And that long-term care is somewhere in the middle, right? You have patients that can be as complex as some of those hospital patients. So, you need more than just a dispense in a retail pharmacy, but you're not going to be in a hospital setting, or you're not going to be in a long-term care facility, like a true SNF setting. And so understanding that spectrum, I think, is really important.
Yeah, and this is where pharmacies can then grow into that clinical billing, that incident to billing, the RPM, and providing those services and those devices and the at-home dispensing devices. And they can grow their revenue in all these different ways because that's where the population's at. That's where the growth is at. But we could do more than just send them drugs. We can help a lot of their clinical needs.
Yeah. Well, I think that's a fantastic statement to end on. We can do more. So this has been really, really fun. We really appreciate you being on the podcast. Tell us about, before we let you go, tell us about your business now, what you do, where people can find you.
Yeah. I kind of get that area of where LinkedIn is the only thing that doesn't change. So, people can always, phone numbers change, email addresses change, they come and go, people move, but LinkedIn, connect with me on LinkedIn, send me a message on LinkedIn. It's probably the one constant, in our life as far as business. But, my focus is to really help as far as strategy and be able to help a pharmacy sit down and look at themselves, look at their opportunities, and then, guide them on the path to be strategic and be creative on ways that they can generate revenue, ways that they can grow their pharmacy, and then connect them with known resources out there. Your company being one of them, a lot of other good software technology companies out there, a lot of packaging companies out there, automation companies out there. And, I've been very, I've had the great pleasure of getting to know a lot of people in this industry. And so I'm usually able to and happily able to kind of connect those pharmacies with the right amount of resources and the right amount of vendors that can really give them what they need to really take off and launch.
Well, awesome. Well, so all of you listeners out there, if that's what you're looking for, if you're looking to figure out which of these many ways to grow you should focus on, and a little bit of help figuring out how you level up your pharmacy, go find Tom on LinkedIn. Really appreciate you being here. And thanks everybody for listening to Amplify Long-Term Care.
Thank you, Frances.
Thank you. Thanks for being with us today, everybody. This is our relaunched pharmacy podcast for long-term care. It's Amplify LTC Podcast, and you can find us on YouTube, Spotify, or Apple Podcasts. Please subscribe and continue to listen for great conversations around long-term care and how to elevate your pharmacy.